you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
He's slightly intoxicated. Got his wrist pain by doing over-aggressive high fives to his buddies.
Quick disclaimer. This is not an evidence-based podcast. These are simply our opinions. These are questions asked of us by a Canadian friend, Chris Byrne, who is helping to organize a big ultrasound conference for Canadian medical students. Listen at your own risk. Hello, Canada. Mike and Matt here. We don't get the chance very often to record together, so we're taking advantage of this opportunity while we're here in Alaska at Alaska Fest. And we also wanted to put you at ease, make you comfortable by recording with a moose, as you can see in the picture. We're really excited for you guys in your conference, partly because you're learning ultrasound, the greatest invention since false teeth, but mostly because we heard Rob Arnfield is there. That dude is dreamy. We'd be there too personally, but one, we're really scared of flannel and Sasquatch, and two, we weren't invited. So let's just answer these questions for you. Number one, why are you so passionate about point-of-care ultrasound? Mike, go.
Well, that one's pretty simple. Ultrasound just makes me a better doctor. It's like cheating. I saw immediately when I was an intern that docs who were good at this had a ridiculous advantage over the ones that weren't. So being an average dude in every other way, I saw this as the ticket out of mediocrity. And if you're already awesome, or Arnfeltish, as we like to call it in the business, then this basically just turns you into a superhero. And if you're developmentally delayed, but your rich uncle bought your way into medical school, well, then this probably just brings you up to mediocre. So great for everyone, especially your patients. So, Matt, what is the difference between point-of-care ultrasound and diagnostic ultrasound?
So, actually, point-of-care ultrasound is diagnostic ultrasound in some cases, and it's also procedural ultrasound in other cases. I think the question here, I think you're referring to point-of-care ultrasound versus consultative ultrasound, and there is a difference there. With consultative ultrasound, a test is usually ordered, and usually a tech comes and takes the images, and then they're read by a radiologist or other consulting physician. Personally, I prefer to be able to answer as many questions as I can immediately at the bedside and strengthen that relationship I have with the patient already and not push an order button to get the answer. And that's what a point-of-care ultrasound is. It's when I do this at the bedside in real time and work this into my decision-making. I still order consultative ultrasounds, but over time the number of things I get consultative ultrasounds for have decreased, which is personally just important to me. If I can get the answer myself immediately at the bedside, then why not? Mike, number 3, does point-of-care ultrasound have applications outside of the emergency room, ICU, or OR?
Absolutely. To be honest, I think psychiatry is probably the only specialty without multiple clear indications for point-of-care ultrasound. We've taught literally every specialty at various courses we've held, including some courses for other specialties only, family medicine, internal medicine. Anyone who wants to actually look into the body at a patient's physiology and pathology can benefit from this technology. All right, question number 4, Matt. Do you think it should be mandatory for physicians who use point-of-care ultrasound to have some sort of certification?
So this is a tough one. I'm really not sure. I kind of would like to say no, but I'm pretty sure I'm in the minority here, and I may change my mind over time. But I have kind of a libertarian bent, and there's not many things I despise more than rules and regulations. I've heard some people use the analogy that we don't have to get certified to use our stethoscope, so why this? Now, that's not a great analogy because I hate comparing ultrasound to the stethoscope. People who do that are giving the stethoscope way too much credit. And I realize that there exists the possibility of people using ultrasound and being possibly dangerous with it because they're so horrible. But that exists for everything we do. I'm not sure another certification test is the answer, but maybe it is. This is purely opinion, and it's only my opinion. So I don't know. Maybe a certification, maybe not. How about that for a waffling answer? I think I'm ready for politics. Mike, number 5. In your experience with other trainees, what do you think the learning curve would be like for medical students learning point-of-care ultrasound?
I think the learning curve is pretty quick. I mean, you guys crush it. You're digital natives. A lot of you grew up playing video games. So when you learn this at the same time you learn anatomy and the physical exam, it just sort of clicks. It's not automatic. You have to work at it like you have to work at everything else, and just like you have to work at life. But I think it's easier than reading x-rays and much easier than reading EKGs. I mean, seriously. Looking at ridiculously squiggly lines at arbitrary labels with numbers and letters representing electrical activity of the heart compared to looking at a video of the heart actually moving, it's totally different. If anyone tells you echo is more difficult than EKG, then walk away before they pollute your mind with other nonsense. They say that only because they've probably looked at like 1,000 EKGs and less than 10 echoes probably. I guarantee you that if you looked at and did as many echoes as you did EKGs in your training, you would see how much easier it is. And I think you'd probably abandon EKGs altogether in a world like that. But now I'm talking crazy, and I'll stop before I get in trouble with some of my really radical ideas.
Yeah, I think it's the same for musculoskeletal ultrasound and x-rays of fractures, as well as ultrasound of the chest versus x-ray of the chest. People just aren't used to ultrasounding these things, but it's pretty incredible when you actually look at it.
All right, question number 6. Matt, what barriers do you predict in trying to implement point-of-care ultrasound into medical education?
So, some people say the barriers are mainly the old farts. A lot of people think it's the more senior members of administration that are resistant, but I found that's not usually the case. It's really the scared farts and the resistant to change farts, which aren't always the elderly administration. It really comes down to people just not understanding, which is a problem we can fix. So, some don't see the value, so you show them. There's piles of literature now. Show them that, a demonstration, and a few case stories, and that's usually sufficient. Others worry that it degrades your physical exam, but that's actually not true at all. Evidence points to the fact that it actually probably improves that. When I examine someone for tamponade or cholecystitis, I get immediate feedback and strengthen kind of the neuronal connections by knowing exactly if I'm right or wrong. So my physical exam gets better. Others will tell you that it's a monetary hurdle. There's not enough space in the curriculum, to which I say horse poop. If you think it's valuable and are willing to change, there are plenty of ways to make it affordable and find the space. They may have to look at the budget and actually make some tough decisions, but that shouldn't be the limiting factor. There are options. I mean, in Canada, you could probably just replace the 6 months you have dedicated to studying the effects of maple syrup toxicity, and that's all you need, eh? So the real hurdle is just people not understanding and being scared to change. But you can calm their fears and show them the light. It's doable. Mike, what would be your first step in bringing ultrasound into an established medical school curriculum?
I think probably the most important thing is to find a champion. Find somebody who's willing to put forth the effort to talk to the curriculum committee and convince them that this is a good idea. And then after that, I would develop an elective. So that's an easy way to get started. People who are interested in ultrasound can do ultrasound during their free time in their 3rd or 4th year whenever they have elective time. Also, hold a big 1 or 2 day course. You can't learn ultrasound in a day, or really even 2 for that matter, but it's enough to get people to see the light. They can get motivated, they can get interested. It'll give them the motivation to push forward and pursue it in depth in their own time. And that can be a really powerful tool. So Matt, question 8. What kind of ultrasound exposure do medical students in the United States receive?
Oh, yeah, well, I mean, here in the U.S., we're light years ahead of the silly Canucks. We're actually working on a preschool ultrasound integration as we speak. The next step is placing tiny probes, I think, in the womb for the fetus to just get used to the tactile feel of the probe. You know, obviously a fetus can't scan, but if we can get them good with basic modalities by 2, then we think, I'm just kidding. It's completely random. You know, some medical schools have full 4-year programs, and others don't have anything. It really completely depends on your school. Mike, what is your response to those who are skeptical of or criticize the use of point-of-care ultrasound?
Let's see, what do I do in response to those who are skeptical or criticize point-of-care ultrasound? Well, normally Matt will kind of lean behind them and I'll push them over Matt's back, and then he moons them and I flip them off. But I guess technically, first off, I think it's important to educate people. And a great way to do that is just give them a talk, discuss the literature, and attempt to enlighten the skeptic. This occasionally works with rational people, but let's be honest, not everybody's rational. So second, I would try demonstration. And by demonstration, I mean I just basically do my regular ultrasound thing in the hospital. Others start to take notice and realize the difference that it makes. Even if someone isn't that rational and changed by the evidence, they're usually emotional, and they'll see me using ultrasound in the emergency department and become jealous and want to be able to do the same things that I'm doing and take the same shortcuts that I'm taking because of ultrasound.
Yeah, I agree, Mike. Education and demonstration are definitely the first 2 things to do. If that doesn't work, though, I really think the last step is shame. For example, if it's someone I'm teaching, they come to me and want to just cut on someone who they aren't sure whether they have an abscess or cellulitis, and it could be either, I shame them. I ask them, are you A, stupid, B, lazy, or C, an evil jerk who hates his patient? And this is only after education and demonstration, after I've told them the evidence and showed them how to do it. So thankfully, this is rare, but it does happen. As for the attendings who I can't quite talk to that way, I shame them by turning their residents and students into freaking scanning machines. So then the attendings see how much better their trainees are than them, and they feel totally ashamed that their reports can better diagnose and perform some procedures. So it's not a primary method, this shame. I definitely think education and demonstration are the two main ways we can affect change. But shaming, sometimes you've got to resort to it, and it's pretty darn effective when it needs to be deployed. So guys, thank you so much for inviting us to talk to you and listening to us. As a gift for making it all the way through our rambling rants, we want to give you all a free copy of our iBooks, Introduction to Bedside Ultrasound, both Volume 1 and Volume 2. We'll give the files to one of your course directors to distribute to you. It's a hacked file because the one on iTunes costs $30. So you do have to download this to a computer and import it into iTunes and then load it onto your iPad. But hey, it's free. Give us a break. And it's worth downloading if for no other reason than watching Rob Arntfield demonstrate TEE. Did I mention how dreamy that dude is? Thanks, guys.
Yeah, thanks for having us.
And we danced, and we cried, and we laughed, and had a really, really, really good time. Take my hand, let's have a blast, and remember this moment for the rest of our lives. Our lives, our lives. Oh, 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 oh. Tonight, cause tonight's the night, am I right? Dance feels like a night for a party. My nature, so naughty. There's a knock on the door, it's the neighbors. Quick cock blocking, we're having a hoedown. You hose down, don't let me pull my hose out. Cause it's big, long, pink, strong. I've been known to dance like all night long. Grab my hand, play this song. DJ, save my life, come on.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.